Hi everyone, this is Doc Ina and this is my lecture on diabetes mellitus in pregnancy. To download my lecture deck, please go to my WordPress site, Doc Ina Obigaide. So normally, pregnancy is accompanied by insulin resistance. And this is mediated primarily by a placental secretion of diabetogenic hormones, including what we call the growth hormone, corticotropin-releasing hormone, placental lactogen, prolactin, and progesterone. These and other metabolic changes ensure that the fetus has an ample supply of nutrients. Gestational diabetes mellitus develops during pregnancy in women whose pancreatic function is insufficient to overcome the insulin resistance associated with the pregnant state. Among the main consequences are increased risk of preeclampsia, macrosomia, and cesarean delivery, and other associated morbidities. Diabetes is the most common medical complication of pregnancy. So we have basically two types of diabetes mellitus during pregnancy. We have the pregestational or overt diabetes, where the patients were known to have diabetes before pregnancy, and gestational diabetes, where the patients were diagnosed with diabetes during pregnancy. In recent years, the International Association of Diabetes and Pregnancy Study Groups, the American Diabetes Association, the WHO, and the International Federation of Gynecology and Obstetrics use the term gestational diabetes to describe diabetes diagnosed during the second half of pregnancy, and terms such as overt diabetes or diabetes mellitus in pregnancy to describe diabetes often diagnosed early in pregnancy when the effects of insulin resistance are less prominent, thus suggesting the presence of pre-existing but unrecognized type 2 or even type 1 diabetes. However, the diagnosis of diabetes mellitus in pregnancy can be made in women anytime in pregnancy who meet glucose criteria for diabetes in the non-pregnant state classification proposed by the American Diabetes Association. And this is shown in this table. So, the ADA criteria for the diagnosis of diabetes will include HbA1c that is greater than or equal to 6.5%, or a fasting plasma glucose of greater than or equal to 126 milligrams per deciliter, or a 2-hour plasma glucose of greater than or equal to 200 milligrams per deciliter, or a patient with the classic symptoms of hyperglycemia or hyperglycemic crisis, and a random plasma glucose of greater than or equal to 200 milligrams per deciliter. So first, let's discuss pregestational or overt diabetes. This is defined as a random plasma glucose level of more than 200 milligrams per deciliter, plus the classic signs and symptoms such as polydipsia, polyuria, and unexplained weight loss, or a fasting glucose level that exceeds 125 milligrams per deciliter. Now, for women with only minimal metabolic derangement, the International Association of Diabetes and Pregnancy Study Groups consensus panel recommends the following threshold values in this table. So we have a fasting plasma glucose of at least 7 millimoles per liter, or that's equivalent to 126 milligrams per deciliter. Hemoglobin A1C or HbA1c of at least 6.5%, and a random plasma glucose of at least 11.1 millimoles per liter, or that is equivalent to 200 milligrams per deciliter plus confirmation. The diagnosis of overt diabetes during pregnancy should be confirmed 6 weeks postpartum, and the risk factors for pregestational or overt diabetes include strong familial history of diabetes, prior delivery of a large newborn, persistent glucosuria, or unexplained fetal losses. The ADA and ACOG define women at increased risk of overt diabetes based on a body mass index or a BMI of greater than or equal to 25 kg per meter squared for Asian Americans, plus one or more of the following: gestational diabetes mellitus in a previous pregnancy, HbA1c that's more than or equal to 5.7%, first-degree relatives with diabetes, high-risk race or ethnicity, and this will include African American, Latinos, Native Americans, Asian Americans, or the Pacific Islanders, history of cardiovascular disease, hypertension or on therapy for hypertension, high-density lipoprotein cholesterol levels less than 35 milligrams per deciliter, and or a triglyceride level greater than 250 milligrams per deciliter, polycystic ovary syndrome, physical inactivity, other clinical conditions associated with insulin resistance, such as severe obesity, acanthosis nigricans, and previous birth of an infant weighing more than or equal to 4 kilograms. There are so many complications associated with pregestational or overt diabetes, and this will include gestational hypertension, preterm birth, macrosomia, fetal growth restriction, stillbirth, and perinatal death. There is actually a threefold increase in the spontaneous abortion rate, and for the preterm delivery, we have a fivefold increased risk for patients with overt diabetes. For congenital malformations, there is a twofold increased risk, and at least three interrelated molecular chain reactions have been linked to maternal hyperglycemia and can potentially explain the mechanism behind poor glycemic control and increased risk for major malformations. And this will include alterations in cellular lipid metabolism, excess production of toxic superoxide radicals, and activation of programmed cell death. There's also altered fetal growth, and the incidence of macrosomia rises significantly when mean maternal blood glucose concentrations are chronically exceeding 130 milligrams per deciliter. There will also be unexpected diminished growth or diminished fetal growth, which may result from congenital malformations or from substrate deprivation due to advanced maternal vascular disease. There is also a higher incidence or a 3 to 4 times higher incidence of unexplained fetal demise among patients with DM type 1. And these unexplained stillbirths are associated with poor glycemic control, hyperglycemia-mediated chronic aberrations in oxygen and fetal metabolite transport may underlie these unexplained fetal deaths. There's also increased incidence of hydramnios because fetal hyperglycemia may lead to polyuria. And there's also increased incidence of preterm delivery, and most are due to advanced diabetes with superimposed preeclampsia. Newborns may experience a rapid drop in plasma glucose concentration or hypoglycemia, that's less than 45 milligrams per deciliter of fetal plasma glucose, due to hyperplasia of the fetal beta islet cells induced by chronic maternal hyperglycemia. Hypocalcemia, which is a serum calcium concentration of less than 8 milligrams per deciliter, can also be experienced by the newborns, and theories include aberrations in magnesium calcium economy, asphyxia, and preterm birth. Newborns may also experience hyperbilirubinemia and polycythemia. Polycythemia is thought to be a fetal response to relative hypoxia, and polycythemia can lead to hyperbilirubinemia. Sources of this fetal hypoxia are hyperglycemia-mediated increases in maternal affinity for oxygen and fetal oxygen consumption. Hypoxia leads to increased fetal erythropoietin levels and red cell production. Cardiomyopathy can also be seen among infants of diabetic pregnancies, and they may have hypertrophic cardiomyopathy that primarily affects the interventricular septum, and this cardiomyopathy may lead to obstructive cardiac failure. Studies found an association between maternal diabetes mellitus and decreased IQ and autism or developmental delay in offsprings of women with diabetes mellitus. As for the inheritance of diabetes, the risk of developing type 1 diabetes if either parent is affected is 3 to 4%, and type 2 diabetes has a much stronger genetic component. If both parents have type 2 diabetes, then the risk of developing it approaches 40%. There's also increased incidence of preeclampsia, and this develops 3 to 4 times more often among diabetic women. The risk factors for preeclampsia include any vascular complication and pre-existing proteinuria with or without chronic hypertension. Patients with overt diabetes are also or have also increased incidence of diabetic nephropathy, and diabetes is of course one of the leading causes of end-stage renal disease. Clinically detectable nephropathy begins with microalbuminuria, that's 30 to 300 milligrams protein per 24 hours. macroalbuminuria, that's more than 300 milligrams of albumin or protein per 24 hours, which develops in patients destined to have end-stage renal disease. In general, pregnancy does not appear to worsen diabetic nephropathy. Diabetic retinopathy may manifest in several stages, and the first is benign or background or non-proliferative retinopathy. The first and most common visible lesions are small microaneurysms followed by blood hemorrhages that form when erythrocytes escape from the aneurysms, and these may lead to a leak of serous fluid that creates hard exudates. Next is the pre-proliferative retinopathy, where abnormal vessels of background eye disease become occluded, which leads to retinal ischemia and infarctions, which we call cotton wool exudates. The ischemia can lead to neovascularization of the retinal surface and out into the vitreous cavity. Vision is obscured when there is hemorrhage, and laser photocoagulation before hemorrhage reduces the rate of visual loss progression and blindness by half. Diabetic neuropathy may manifest as diabetic gastropathy, and this causes nausea, vomiting, nutritional problems, and difficulty with glucose control. Women with gastroparesis should be advised that this complication is associated with a high risk of morbidity and poor perinatal outcome, and treatment is usually with metoclopramide and H2 receptor antagonists. Diabetic ketoacidosis or DKA may develop with hyperemesis gravidarum, beta-mimetic drugs given for tocolysis, infection, and corticosteroids given to induce fetal lung maturation. DKA results from an insulin deficiency combined with an excess in counter-regulatory hormones such as glucagon, which leads to gluconeogenesis and ketone body formation. The ketone body beta-hydroxybutyrate is synthesized at a much greater rate than acetoacetate, which is preferentially detected by commonly used ketosis detection methodologies. Serum or plasma assays for beta-hydroxybutyrate more accurately reflect true ketone body levels. So this table shows us the protocol that is recommended by the ACOG for the management of DKA during pregnancy. So we see here that we give low-dose intravenous insulin at a loading dose of 0.2 to 0.4 units per kilogram and a maintenance dose of 2 to 10 units per hour. We also start isotonic fluids with a total replacement in the first 12 hours of 4 to 6 liters. We begin a 5% dextrose in normal saline when glucose plasma level reaches 250 milligrams per deciliter. As for potassium, if initially normal or reduced, an infusion rate of up to 15 to 20 mg per hour may be required. If elevated, we wait until the levels decrease into the normal range and then add to intravenous solution in a concentration of 20 to 30 mg per liter. We also add 1 ampule of bicarbonate, that's 44 mg to 1 liter of 0.45 normal saline if the pH is less than 7.1. Now, how do we manage diabetes in pregnancy? Of course, we start with preconceptional care. The optimal preconceptional glucose control using insulin are the following. So, the preprandial glucose level should be 70 to 100 milligrams per deciliter. Peak postprandial values of 100 to 129 milligrams per deciliter, and a daily glucose concentration of less than 110 milligrams per deciliter. Glycosylated hemoglobin or HbA1c, which reflects an average of circulating glucose for the past 4 to 8 weeks, is very useful to assess early metabolic control. And the optimal value for HbA1c is less than 7%. If indicated, evaluation and treatment for diabetic complications such as retinopathy or nephropathy should be instituted before pregnancy. And we also recommend folate or folic acid 400 micrograms daily, preconceptionally or periconceptionally and during early pregnancy to decrease the risk of neural tube defects. As for insulin treatment, the overtly diabetic pregnant woman is best treated with insulin, and maternal glycemic control can usually be achieved with multiple daily insulin injections and adjustment of dietary intake. Subcutaneous insulin infusion by a calibrated pump may be used during pregnancy. How do we monitor? Self-monitoring of capillary glucose levels using a glucometer is recommended because this involves the woman in her own care. Glucose goals recommended during pregnancy are shown in this table. So for fasting, our goal is less than 95 milligrams per deciliter of blood glucose. Now for the 1 hour postprandial, our goal is blood glucose of less than 140 milligrams per deciliter, and a 2 hour postprandial goal of less than 120 milligrams per deciliter. And the goal HbA1c is less than 6%. As for the diet, nutritional planning includes appropriate weight gain through carbohydrate and caloric modifications based on height, weight, and degree of glucose tolerance. The mix of carbohydrate, protein, and fat is adjusted to meet the metabolic goals and individual patient preferences, but 175 grams minimum of carbohydrates per day should be provided. Carbohydrates should be distributed throughout the day in 3 small to moderate sized meals and 2 to 4 snacks. Actually, weight loss is not recommended during pregnancy, but modest caloric restriction may be appropriate for overweight or obese women. An ideal dietary composition is 55% carbohydrate, 20% protein, and 25% fat, of which less than 10% is saturated fat. So how do we manage diabetic women during the second trimester? Maternal serum alpha fetoprotein determination at 16 to 20 weeks gestation is used in association with targeted sonographic examination at 18 to 20 weeks to detect neural tube defects and other anomalies. Maternal alpha fetoprotein levels may be lower in diabetic pregnancies, and interpretation is altered accordingly. Because the incidence of congenital cardiac anomalies is 5 times greater among mothers with diabetes, fetal echocardiography is an important part of second trimester sonographic evaluation. Euglycemia with self-monitoring continues to be the goal in management. How about management of diabetes in the third trimester? The ACOG suggests initiating fetal surveillance testing starting at 32 to 34 weeks gestation, with fetal movement counting, periodic fetal heart rate monitoring, intermittent biophysical profile evaluation, and contraction stress test. Patients are routinely instructed to perform fetal kick counts beginning early in the third trimester. At 34 weeks, admission is offered to all insulin-treated women. While in the hospital, they continue daily fetal movement counts and undergo fetal heart rate monitoring 3 times a week. Delivery is usually planned for 38 weeks. So this is the insulin management during labor and delivery. So the usual dose of intermediate-acting insulin is given at bedtime. Morning dose of insulin is withheld. Intravenous infusion of normal saline is begun, and once active labor begins or glucose levels decrease to less than 70 milligrams per deciliter, the infusion is changed from saline to 5% dextrose and delivered at a rate of 100 to 150 milliliters per hour to achieve a glucose level of approximately 100 milligrams per deciliter. Glucose levels are checked hourly using a bedside meter, allowing for adjustment in the insulin or glucose infusion rate, and regular or short-acting insulin is administered by intravenous infusion at a rate of 1.25 units per hour if glucose levels exceed 100 milligrams per deciliter. So for the second part, we discuss gestational diabetes. So how do we diagnose gestational diabetes? There's the two-step approach and the one-step approach. And actually, up to this day, there's really no consensus as to which approach is better. So let's begin with the two-step approach. Screening should be performed between 24 and 28 weeks AOG in those women not known to have glucose intolerance earlier in pregnancy. So we start with a 50 grams screening test as a 50 grams OGCT, which is followed by a diagnostic 100 grams 3R oral glucose tolerance test or 100 grams OGTT if screening results for 50 grams OGCT is positive. For the 50 grams OGCT, the plasma glucose level is measured 1 hour after the 50 grams oral glucose load without regard to the time of day or time of last meal. The ACOG recommends using either 135 or 140 milligrams per deciliter as the 50 gram screen threshold. Now, if we use the one-step approach, we use the 75 grams OGTT. The World Health Organization and now the American Diabetes Association recommends the 75 grams 2-hour oral glucose tolerance test in screening for GDM or gestational diabetes mellitus. Now, shown here in the table is are the threshold values for the diagnosis of gestational diabetes mellitus. So for fasting, we have 5.1 millimoles per liter, which is equivalent to 92 milligrams per deciliter. A 1 hour OGTT of 10 millimoles per liter, which is equivalent to 180 milligrams per deciliter, and a 2-hour OGTT of 8.5 millimoles per liter, or which is equivalent to 153 milligrams per deciliter. Nowadays, we only use the fasting and that second hour OGTT. So this table shows us the recommended screening strategy based on risk assessment for detecting GDM. So GDM risk assessment should be ascertained at the first prenatal visit. We label our patients as low risk if this patient is a member of an ethnic group with a low prevalence of GDM, there's no known diabetes in the first degree relatives, the age is less than 25 years old, the weight is normal before pregnancy, the weight is normal at birth, there's no history of abnormal glucose metabolism, and there's no history of poor obstetrical outcome. Now, for these patients, blood glucose testing is not routinely required. For the average risk, we perform the blood glucose testing at 24 to 28 weeks using either the one-step procedure or the two-step procedure. And for the high risk, we perform blood glucose testing as soon as feasible, usually during the first prenatal checkup. And using the procedures described above, if one or more of these are present, severe obesity, strong family history of type 2 diabetes, previous history of GDM, impaired glucose metabolism or glucosuria, or if GDM is not diagnosed, blood glucose testing should be repeated at 24 to 28 weeks gestation or at any time symptoms or signs suggest hyperglycemia. These are the maternal and fetal effects of GDM. The ADA, or the American Diabetes Association, stated that fasting hyperglycemia of more than 105 milligrams per deciliter may be associated with an increased risk of fetal death during the final 4 to 8 weeks. There's also increased frequency of hypertension in cesarean delivery, and increased frequency of cesarean delivery may be due to or secondary to macrosomia or fetal macrosomia. There's also increased frequency of neonatal hypoglycemia and maternal obesity. So how do we manage patients with GDM? Pharmacological methods are usually recommended if diet modification does not consistently maintain the fasting plasma glucose levels less than 95 milligrams per deciliter, or the 2-hour postprandial plasma glucose of less than 120 milligrams per deciliter. The fasting capillary glucose level should be kept at less than or equal to 95 milligrams per deciliter. As for the diet, the ADA recommends individualized nutritional counseling based on height and weight. Nutritional instructions generally include carbohydrate-controlled diet sufficient to maintain normal glycemia and avoid ketosis. On average, this includes a daily caloric intake of 30 to 35 kcal per kilogram. The American College of Obstetricians and Gynecologists, or the ACOG, suggests that carbohydrate intake be limited to 40% of total calories, and the remaining calories are apportioned to give 20% as protein and 40% as fat. And although the most appropriate diet for women with gestational diabetes has not been established, the ADA has suggested that obese women with a BMI of greater than 30 kilograms per meter squared may benefit from a 30% caloric restriction, which approximates about 25 kcal per kilogram per day. And this should be monitored with weekly assessment for ketonuria, which has been linked with impaired psychomotor development in offsprings. For exercise, the ACOG recommends a moderate exercise program as part of the treatment plan for women with gestational diabetes mellitus. For glucose monitoring, the American College of Obstetricians and Gynecologists, or the ACOG, recommends 4 times daily glucose monitoring performed fasting in either 1 or 2 hours after each meal. And the table here shows us the target blood glucose values for pregnant diabetic women. So we have fasting glucose that should be less than or equal to 95 milligrams per deciliter, and a 1 hour postprandial glucose of less than 140 milligrams per deciliter, and a 2 hour postprandial glucose of less than 120 milligrams per deciliter. Now, for insulin, insulin is added if fasting levels persistently exceed 95 milligrams per deciliter in women with GDM. The ACOG also recommends that insulin be considered among women with 1 hour postprandial levels that are persistently exceeding 140 milligrams per deciliter, or those with 2 hour levels above 120 milligrams per deciliter. Now, if insulin is initiated, the starting dose is typically zero point 0.7 to 1 units per kilogram per day, given in divided doses. A combination of intermediate acting and short acting insulin may be used, and dose adjustments are based on glucose levels at particular times of the day. Now, is it safe to give oral hypoglycemic agents in patients with GDM? Yes, in the form of glyburide and metformin, and several studies have actually attested to the safety and efficacy of GDM treatment with either glyburide and or metformin. The ACOG acknowledges that both glyburide and metformin are appropriate, as is insulin, for first-line glycemic control in women with GDM. And because long-term outcomes have not been studied, the committee recommends appropriate counseling when hypoglycemic agents are used. Now, how about the mode of delivery? The ACOG states that cesarean delivery should be considered among women with gestational diabetes mellitus whose fetuses have a sonographically estimated fetal weight of more than or equal to 4.5 kilos. Now, among women with GDM and adequate glycemic control, then these women are managed expectantly. And the ACOG has concluded that there's no evidence-based recommendation that can be made regarding delivery timing in women with GDM with adequate glycemic control and a non-macrosomic fetus on ultrasound. The fifth International Workshop Conference on GDM recommended that women diagnosed with GDM undergo evaluation with a 75 grams oral glucose tolerance test at 6 to 12 weeks postpartum and other intervals thereafter. The ACOG recommends either a fasting glucose or the 75 grams 2-hour OGTT for the diagnosis of overt diabetes, and the ADA recommends testing at least every 3 years in women with a history of gestational diabetes but normal postpartum glucose screening. That's it for my lecture. Thank you for watching. And please don't forget to subscribe in my YouTube channel and my WordPress site, Doc Ina Obigaine.